Hello, I'm Dr. Ayesha Siddika and I'm a GMC registered doctor and I have been working in medicine for the previous 5 years. Currently, I'm preparing for my Royal College exam and I'm going to share the topic I'm reading with you so that we can both prepare together. Okay? So, first topic I'm going to discuss is asthma. So, what is asthma? It is a chronic inflammatory airway disorder characterized by airway hyperresponsiveness. Okay, recently its prevalence has been increased, particularly among children, and incidence also higher in children. Okay, so during childhood, it is more common in boys than the girls, but during adulthood, the ratio is reversed. Now we are going to discuss about etiology and triggers which can lead to asthma. So first of all, the development of asthma is likely to be due to combination of genetic factor and also environmental factor. So there is some genetic factor like if you have any history of atopy or any family history of atopy, then it can contribute to have asthma. So and there are some allergen or like if you get exposed to some allergen which can lead to airway hyperresponsiveness like smoke, fumes, sprays, dust, flour, isocyanates. Okay, so this allergen can lead to airway hyperresponsiveness, ultimately contribute to asthma. And if you get a respiratory tract infection in childhood, it also a risk factor for asthma. And if you are obese or you have obesity, then it may contribute to asthma. So what are the etiology? Like there are some genetic predisposition and some environmental factor. So if you expose to allergen, if you have family history or you have history personal history of atopy or any respiratory tract infection in childhood or obesity, it all contribute to asthma. There are beside this there are some triggers which can also lead to asthma, like cold weather, infection, like we have already mentioned that respiratory tract infection can contribute to this. There are another disease that is gastroesophageal reflux disease, so it also contribute to asthma due to recurrent reflux of gastric content into the esophagus. Okay, and there are some drugs which can contribute to asthma, and it is I have made a mnemonic for that, that is ban. BAN. B for beta blocker, A for aspirin, N for NSAIDs. So BAN. Ban. Ban asthma. Ban drugs for asthma, that is beta blocker, aspirin, NSAID. Now we'll know about the clinical presentation. So the hallmark of asthma is the variable and reversible airflow obstruction. So how will I understand that it is variable and reversible airflow obstruction? There will be mm, symptoms like shortness of breath, chest tightness, wheeze, coughing, and these symptoms will may have diurnal variation, which means the symptoms may get worse during night or in the morning during cold weather, and there may be no symptoms at all for certain amount of time, certain period of time. Okay, and chronic asthma. Now we'll know about chronic asthma, how we can understand that is chronic asthma. So the respiratory rate will be high and there will be wheeze at the marked on the expiration, and there will be hyperinflation, and there may be history of nasal polyp, and mostly it happens with aspirin sensitive asthma, and there may be atopic eczema. So this patient may have eczema, polyp, hyperinflation, and who is that is more marked on expiration, and respiratory rate will be high, that is tachypnea. There are some symptoms we have already mentioned that can lead to asthma, And we need to consider asthma with some history, like if there is any history of asthma, eczema, nasal polyp, or hay fever, allergic rhinitis, or chronic synovitis, or family history of asthma, then we should look for asthma. And if the symptoms worsen on night or early morning, it will also give clue for asthma. And we'll tell the patient to maintain a peak expiratory flow rate daily. If there is any diurnal variation, then we can think about asthma. And in blood, if we find eosinophilia, or if we find there is some immunoglobulin E raised, then we can uh, think about excluding asthma. Okay. So during when how can we diagnose the asthma? If patient is less than 5 years, then we will need to depend on clinical symptoms, like we have mentioned that there may be history of shortness of breath, chest tightness, wheeze, cough, and some history of some diseases or family history. Based on that, like the symptoms will be variable and reversible, airflow obstruction. Uh, so the with these symptoms, we can diagnose if patient is less than 5 years. So less than 5 years, we usually do not do any objective test like spirometry or bronchodilator reversibility or fractional exhale nitric oxide level. So if a patient is 5 to 16 years, then we'll do the objective test, which test bronchodilator reversibility and spirometry. So spirometry and bronchodilator reversibility. If these tests are inconclusive, then we may need to do fractional exhale nitric oxide. And at age 17, if we find any patient on 17, then we must do the fractional exhale nitric oxide test, also spirometry and bronchodilator reversibility. That means we need to do all the objective tests at the age of 17. And in case of occupational asthma, like a symptom get worse on work days and a symptom relief on holidays, in that case we'll need to do specialist referral. So what are the objective tests and their findings? So first of all, we have mentioned that at age 17 we must do fractional exhaled nitric oxide. So what will be the level? If it is 40 parts per billion or more, and with bronchodilator reversibility test or peak expiratory flow rate variability and bronchial hyperactivity, we can diagnose asthma. And if the FeNO level is 25 to 39, then we'll need to do bronchial challenge. If it is positive, then we can say that it is asthma. If irrelevant fractional exhale nitric oxide, then we'll need to do bronchodilator reversibility plus peak expiratory flow rate variability to diagnose asthma. So what will be the spirometry finding? The lung volumes will be increased, fractional X and FEV1 will be reduced, and FEV1 FBC ratio will be less than 70%. And peak expiratory flow rate variability will be find more than 20% difference after measuring twice daily for 2 to 4 weeks. And bronchodilator reversibility, there will be more than 15% improvement in peak expiratory flow rate, or more than 200 ml improvement in FEV1 after bronchodilator or oral or inhaled steroid administration. Then histamine or methacholine exercise challenge test, we can do that. This challenge test with histamine methacholine exercise. What will happen if we introduce this? So there will be airway hyperresponsiveness, there will be bronchoconstriction, so patient will be symptomatic. So it will prove that patient has asthma, and plasma level of carbon dioxide will be less than or equal to 8 milligram per milli. And what will be the skin prick test? We can diagnose the atopy or asthma. So at atopy or asthma, there will be immunoglobulin E will be raised, and we can detect a serum specific immunoglobulin E by a radio allergy sorbent test. So what we'll do at skin prick test, we'll introduce tiny amount of allergen into the superficial layer of dermis. We'll check after 20 minutes there will be wheal formation, and we'll measure the diameter in uh, millimeter. Then we can detect if there is large wheal, then we can say that skin prick test is positive. We'll discuss the asthma management as it is very important in the next video. Okay, thank you, and thank you again.